Welcome to this second episode of this vodcast series on aviation and flight physiology. As was mentioned in part 1 of this series, these vodcasts are based on a lecture previously given by Dr. David Cooksley. I have modified them slightly to better fit the vodcast format and re-recorded the audio to try and improve the quality of the sound. The quality of the content, however, remains as per David's excellent original lecture. In the first part of this series, we looked at atmospherics and the basic gas laws and how they impact on aeromedical retrieval. In this vodcast, we will spend some time discussing some applied flight physiology and begin to look at some of the impact of the transport environment in general. When looking at applied flight physiology, we will begin with a topic dear to the heart of any medical practitioner, and those working in the retrieval environment are perhaps even more sensitive to this topic, and that is the area of hypoxia. Hypoxia can be defined as oxygen deficiency in body tissues sufficient to cause impairment of physiological function. And typically it is divided into the following 4 types. Hypobaric hypoxia, or sometimes it's referred to as hypoxic hypoxia, is where there is insufficient oxygen available due to either insufficient barometric pressure to drive oxygen down the oxygen cascade as seen at altitude, or an insufficient percentage of oxygen for the patient's requirements. In the first vodcast, we spent some time looking at how pressure changes will result in decreased partial pressure of oxygen at altitude. Anemic hypoxia is where there is plenty of oxygen available, but there is insufficient transport substance, i.e. the red blood cells, such that oxygen just can't be transported in the blood. Stagnant hypoxia, or circulatory hypoxia, is where the oxygen is available, as is the transport vehicle, i.e. there's plenty of blood, but the blood itself isn't flowing appropriately, maybe due to a localized obstruction, or much more likely as we are to encounter in our environment, because of physiological shock, be that due to either pump failure or pipe failure. The fourth, and probably the least common cause, is that of histotoxic hypoxia. This is where some toxic substance interferes with the ability of the tissues to utilize the oxygen available. i.e. the oxygen is transported, it is bound, it gets to the cells, but the cells are unable to use it. The classic example of histotoxic hypoxia is that of cyanide toxicity. Cyanide inhibits the ability of the mitochondrial cells to utilize oxygen to create ATP, and this is done through its actions on mitochondrial enzymes. So in our environment, any and all of the listed conditions here may contribute to the development of hypoxia. Maximum altitude, rate of ascent, which limits the ability to acclimatise, and the total time spent at altitude will all impact on the likelihood of tissue hypoxia. Other factors such as the underlying patient characteristics, be that their physical fitness, their actual oxygen requirement due to their current physical activity, i.e. are they moving around a lot, or their underlying metabolic rate. Other things such as whether they have alcohol or medication on board, which impact oxygen requirements and utilisation, as well as whether they have had a degree of acclimatisation due to an extended period of relative oxygen insufficiency, can all impact. And then combining with these background physiological and environmental factors will be the clinical condition of the patient themselves, any of which can lead to one or more of the 4 pathophysiological conditions causing hypoxia that were described on the previous slide, i.e. problems with gas exchange, problems with oxygen carriage, problems with circulation, or problems with utilisation. At this point, it's important to remind ourselves of the physiology around oxygen utilisation by the cells for the creation of energy, or ATP. Whilst oxygen is carried by haemoglobin, there is actually no active transport per se of oxygen across cellular membranes. For oxygen to get into the mitochondria from the atmosphere, it relies on a pressure gradient, obviously going from a higher to a lower pressure, or downhill so to speak. Oxygen must diffuse down the gradient, across the alveolar walls and interstitium, through the capillary walls and onto the red blood cell. As these red blood cells circulate, the oxygen that must then continue to diffuse down a gradient into the tissues, and then from the tissues into the cellular mitochondria itself, where only there can it be utilised for energy creation. Obviously, anywhere along this gradient there may be impediments to diffusion from underlying pathological processes, or due to environmental circumstances of some sort. When we look at oxygen carriage in the blood itself, once it has exited the alveoli, then we know that it is carried in two ways. Firstly, and primarily, oxygen is bound to haemoglobin, with around 1.39 mils of oxygen transported per gram of haemoglobin. The second way oxygen is transported in blood is dissolved directly in the plasma. The amount of dissolved oxygen is directly proportional to the barometric pressure, as stated by Henry's law. If we remind ourselves, this law states that the amount of gas dissolved in a solution is directly proportional to the pressure of the gas in contact with that liquid. So theoretically, if we lived in a hyperbaric chamber with the pressure set high enough, we could actually survive without any red blood cells, purely on the oxygen dissolved in plasma and transported that way. This graph highlights a common misconception that is often made in critical patients. Let's look at this oxygen hemoglobin dissociation curve for a patient with a hemoglobin of 75. Despite the fact that we spend a lot of time considering and monitoring oxygen saturations, primarily because it is easy to measure on a beat-by-beat basis using a saturations probe, the tissues themselves are primarily concerned not with saturation but with total oxygen content, i.e. what is the total volume of oxygen that is being delivered to them. It is oxygen content that the cells require to function adequately. Low oxygen content with normal oxygen saturation will still result in tissue hypoxia. So an anemic patient will be 100% saturated, but the total oxygen content of their blood may be sufficiently low that the cells are in effect hypoxic. In this graph, we can see that in a patient who has a hemoglobin of 75, they are only carrying 100 ml per litre of oxygen in their blood. They will, however, still be 100% saturated. However, if you look across to the left of the graph, we can see that 100 ml of oxygen is the equivalent of a patient saturating at 50% who has normal hemoglobin. So a profoundly anemic patient saturating 100% can still be significantly hypoxic at a tissue level. This is especially important for us to consider, because patients that are significantly anemic, whilst they may cope adequately at sea level, once they are taken to altitude, they may continue to deteriorate physiologically, despite being 100% saturated. In these circumstances, it may be beneficial to request a sea level cabin to try and optimise their tissue oxygenation, and perhaps have a slightly lower threshold for red blood cell intrusion than you would have normally. Sticking with the oxygen hemoglobin dissociation curve, one of the key points to remind ourselves is that the curve is sigmoid shaped and not linear. This is physiologically advantageous, as it allows us to onload and offload large amounts of oxygen for relatively small pressure changes. But let's consider the effects of being at altitude of around 3,000 metres or 10,000 feet without supplemental oxygen. So at a height really just over the maximum height that rotary aircraft will fly and that fixed-wing aircraft are pressurised to. At this altitude and barometric pressure, we will have an arterial PO2 of around 60 millimetres of mercury. This will result in most healthy people in SATs of around 89%. And this is for individuals who are healthy and who have a starting point of 98 to 100% saturations and a PaO2 of 90 to 100 millimetres of mercury at ground level. But let's consider then the situation of a patient who is already marginally hypoxic at sea level before even getting to altitude. So whilst we can generally be relatively complacent about a patient with SATs on room air of around 91 to 2% generally, the key point here is that they are already at the junction of the shallow part of the curve with the steep drop-off part of the curve. Hence a small change in pressure, such as putting them in a plane or helicopter, will result in quite a precipitous drop in saturation. So what are the practicalities of this? Let's consider the following situation. We've got a 65-year-old COPD patient who's acutely short of breath. He's been getting 15-minute nebs for the last 3 hours and is a known CO2 retainer. Our physical examination or assessment reveals an increased respiratory rate of 40, obvious extra work of breathing. He's got an externally audible wheeze and saturations of around 90%, with an arterial PaCO2 of 50%, and that's on 50% oxygen. So the question we have is, can we continue oxygen therapy during transport to the receiving hospital? So at this point we should remind ourselves of Dalton's law. We know that at sea level, atmospheric oxygen is at a pressure of around 159 millimeters of mercury. Water vapour pressure of inhaled gas at this altitude will reduce it slightly to about 150 millimeters of mercury at alveolar level if we want to be strictly accurate. But for this example, I think we can ignore our water vapour pressure. So as we ascend to altitude, the barometric pressure drops. So atmospheric pressure of oxygen also drops. So let's consider a cruise altitude of 6,000 feet, where the barometric pressure will now be down to 600 millimeters of mercury, meaning the atmospheric oxygen pressure is down from the 159 millimeters we calculated at sea level to around 128 millimeters of mercury. Now if we take this information, let's consider the oxygen cascade on this graph, and we can see the true significant impact of that change. As we've already discussed, the oxygen cascade relies on pressure difference to drive oxygen perfusion. As we remember, oxygen doesn't have any active transport mechanisms across cell membranes. It relies on that pressure gradient. So with the drop in atmospheric pressure as we ascend, the cascade or gradient will become less steep, leaving a much shallower diffusion gradient. So let's return to our case. If the patient needs 50% inspired oxygen on the ground to maintain SATs around the 90% range, this means the patient, due to her underlying pathology, needs an atmospheric oxygen pressure of around 380 millimeters of mercury to generate an arterial oxygen pressure, a PaO2, of around 80 to 100 millimeters of mercury to generate SATs of just greater than 90% or so. So at 6,000 feet, where the atmospheric pressure of oxygen is 609 millimeters of mercury, we will need to rearrange the equation so that 609 times whatever percentage of oxygen will give us a big AO2 of 380. So if we rearrange the equation, we see that 380 over 609 gives us an inspired oxygen concentration of 62% to maintain her saturations at her current range. So whilst increasing the FiO2 from 50 to 62% may not seem like such a huge amount, it does show that we have less room for manoeuvring should the patient's condition deteriorate at altitude. Now this calculation that we've just undertaken is most often be required in patients on non-invasive ventilation who generally will have quite high FiO2 requirements. And we do this calculation to see how much leeway is available when transporting them by air at altitude. Within this consideration is also the fact of how much oxygen the patient is actually consuming as a volume in litres per minute, and then factoring this into the transport time to give the total oxygen requirement for the trip. Once this is ascertained, then the total oxygen volume that is available on the transport platform needs to be ascertained to ensure there is enough for the journey. Most texts and aeromedical providers suggest that you need at least half the volume again from your calculation to allow for changes in patient condition, as well as possible destination changes for the aircraft may be due to weather or mechanical issues, so a degree of fat in the system. So moving on, let's consider how hypoxia itself may manifest. This can actually show quite considerable patient variation and may initially be unrecognised. Some of the symptoms we see listed here may in fact lull people into a false sense of security. However, as hypoxia progresses, then signs will become a little more apparent, with limited attention span, impaired memory, deterioration in visual function and colour perception, all progressing on to impaired judgment and impaired psychomotor performance. And if things get bad enough, then we'll eventually get to the point of no return, where the progressive psychomotor impairment will lead to unconsciousness and then ultimately to death. The net effect of this is that we should measure oxygen saturations of our patients on the ground and then ensure we use oxygen during the flight to maintain them at least the same level. In those patients with an obvious significant oxygen requirement, it may be beneficial to measure an arterial blood gas just to better quantify those requirements, and then you can be much more accurately ascertain if there is sufficient reserve to enable you to take the patient to altitude. If the patient has a degree of critical hypoxia on the ground, it may well be that you need to rethink your oxygenation strategy before exposing them to the risks associated with aeromedical retrieval. This somewhat busy table can be very helpful and is taken from the military MCAT training manual and illustrates this issue nicely by showing how much room or lack of room you may have when managing your patient. When we look at this graph or table, it has cabin altitude on the y-axis and fraction of inspired oxygen on the x-axis. Consider the patient who is intubated at sea level and requires an FiO2 of 85% or 0.85 to maintain their saturations at around 92%. To keep the patient's saturations at the same level, the table shows us how much the FiO2, or fraction of inspired oxygen, will have to be increased as the altitude increases. So at 5,000 feet, the patient will require an FiO2 of 1 or 100%. And at any altitude above that, will be unable to deliver enough oxygen to maintain the ground level saturations. At these altitudes, the patient will become progressively more hypoxic. It's also important to note point 4 on this table. This reminds us that this is only a measure of saturation, not oxygen content. So again, anemia and other patient conditions like increased VQ mismatch or loss of recruitment need to be factored in as well. I like this table and find it very useful in that it has used the barometric pressures at each altitude, so that in fact we don't need to consider those for ourselves or remember them. I'd actually recommend pausing the vodcast at this point to look more closely at this table and to reassure yourself you understand how it works and the physiological principles behind it. Now we're going to move a little bit away from hypoxia and oxygen delivery and focus a little bit in the last part of this segment on how some of the pressure changes and their concomitant volume changes will affect the body within the context of a clinical case. So let's consider the details of this case. We've got a 25-year-old male who's been riding a motorbike and has crashed into a tree. It won't surprise many to know that he left the pub a little bit early in the evening, quite obviously intoxicated, and he was last seen walking towards the motorbike eating a kebab. On your arrival, you assess him to have a GCS of 7. You think he's probably got decreased breath sounds on the left, but does have good chest rise and fall, and his saturations are currently 98% on a non-rebreather mask. His heart rate is 90, and he's got a systolic blood pressure of 90. He's got a penetrating head injury from the visor of his helmet, and we're a 55-minute fixed-wing flight to our destination. Now, for those listening to this podcast from a paediatric neonatal background, don't be put off by the age and size of the patient. The physiological principles are the same. This could just as easily be a 9-year-old riding a push bike down a hill at a birthday party with a tummy full of Fanta and Ferrofloss. So on with the case. The team springs into action. They intubate and ventilate the patient. IV access is optimised and fluids are hung in a pressure bag for delivery if required. An orogastric tube is placed after the patient is intubated and the patient is carefully positioned on a vacuum mattress. It's at this point that discussion in the team starts around the need, or otherwise, to formally decompress the chest, either with a finger thoracostomy or perhaps with a more formal chest tube and an underwater seal. So it's in this situation that we start to consider Boyle's law. And mixed in with that is the fact that he's also being positively pressure ventilated. We know, according to Boyle's law, if the patient does have a pneumothorax, then that will expand as we go to altitude. And I guess the big point we have to consider is whether it will expand enough to be significant and to cause problems for the patient. At this point, it's also worthwhile thinking of other gas-filled spaces that will also be impacted by the transport of this patient at altitude. So when considering these factors of gas-filled spaces, I always think it's beneficial to consider them in two categories, i.e. those that affect the patient and those that affect the equipment that we're using. So let's start with the patient factors. So where are the places that trapped gas may create an issue? In the case we're just describing, the obvious ones are head, eye, chest, and possibly his gut. Now, some of those areas we can do something about, hence the value in placing a large bore orogastric tube to try and decompress the stomach. And this is the other reason why we're considering placement of a chest tube or undertaking finger thoracostomy, because we are able to decompress those areas and release the gas contained. However, some of the areas we've just discussed, there's very little we can do about. And we just have to be aware of them and try and mitigate any potential adverse effects by how we manage the patient and how we manage the environment. So this may well be by appropriate posture and perhaps by changing or requesting low-level cabin pressures. I think it's worthwhile noting at this point that we often request a sea level cabin, but in fact if the patient is already above sea level, then it is probably more correct to request a ground level cabin. It's no big deal because generally pilots will know what you mean, and they're quite happy to engage in this aspect of the flight planning considerations with you. So once we've considered the patient spaces where gas can be trapped, it's also worthwhile considering about the equipment issues. In this particular patient, we should probably consider tracheal cuff pressures. We used to advocate filling those with water. We now continue to fill them with air, but monitor them regularly using a pressure manometer and just as appropriate. Other important points to note: pressure bags will become firmer, vacuum mattresses will become softer, and drainage bags, such as those connected to the orogastric tube, will also become fuller. And if not watched closely, they have occasionally been seen to explode or leak. Not a good look for the inside of your aircraft. Moving on from this case, other gas-filled cavities, not directly related to this particular case as I've just said, but that should be considered in general, include dental cavities and GI systems, such that often in the case of dental problems, this can cause significant problems for crew and staff if it's a regular current, and GI systems also need to be considered, particularly for those patients who may be transported as part of a secondary retrieval and perhaps may have a subacute bowel obstruction. A particular problem can be the middle ear, especially if people have upper respiratory tract infection, which seems to be an almost permanent state in some kids. And in some, this can cause severe pain, and especially in children who may find it difficult to equalise. It is worthwhile having a management strategy for these occurrences in children, usually something to suck on, such as a pacifier, or if old enough, something to blow through. A syringe is useful, or maybe a straw, and this can often help to equalise the middle ear for these particular patients. This diagram illustrates nicely the issue and demonstrates how that if the eustachian tube is blocked or narrowed, then the middle ear cavity is unable to effectively equalise. As well as ears, the same problem can occur with sinuses, with some patients, and crew members for that matter, getting quite painful maxillary or frontal sinus pain, particularly with changes in altitude, and particularly in the presence of upper respiratory tract infection or allergic rhinitis or hay fever. It is important to remember that pressure changes on the way up as well as on the way down. I'm going to finish this part of the vodcast here before moving on to part 3. There's been quite a bit of information in this part, looking more at the specifics of flight physiology as it applies to patients and crew. Specifically, we've touched on hypoxia and its categorization, oxygen carriage and the oxygen hemoglobin dissociation curve and its relevance to aeromedical retrieval as well as the oxygen cascade. We've also looked at oxygen and hypoxia in a clinical context and looked at how some of the gas laws relate specifically to patients in our care as well as the equipment we use to transport them. In the third and final part of this series, we will deal with the physiology and biomechanics related to movement and noise, and specifically look at how this can impact directly on patients in our care as well as on ourselves working in the aeromedical retrieval environment.